All right, let's talk about itching. Take a look at this picture.
Yes.
Right? So full disclosure, this was given to me by Robert Mitchell from the PBC Foundation. I'm immensely grateful that they shared this with me. This was strong work by them. Look at this. This is the word cloud for how you guys describe the impact of PBC in your lives, the symptoms, the burden. It's quite striking, right? And then if you remove the words that came more often, like the itching and the anxiety, then look at this. Itching, achy, pain, anxious, dry. It affects your lives, and you know that, of course, better than me. I think it's good to see that you're not alone. This is the perception, and I'm going to share more with you about different ways that itching affects lives of patients with PBC. And not all patients, not everyone with PBC itches, thankfully. And that doesn't mean that you will at some point in your disease course. It affects 20 to 70% roughly of patients with PBC in the course of the disease. Most of the times, the itching will be very mild, in your words. And that's whatever mild means, right? I will get to another point that discusses what really that, how discrepant this thought could be. But most of the patients will report mild itching, a third will have moderate, and fewer than 5% will report severe itching. Now, target PBC, you might be familiar with that. Some of you may have participated in the target PBC. This is an observational study done across the nation. We have 35 sites, academic and community sites, where we collected, so patients with PBC signed a consent form and allowed us to review their medical records to understand the disease course, many aspects of the disease course, the presentation, progression, treatment, and itching. And some of you agreed to have questionnaires sent to you to report on the symptoms, right? So based on these questionnaires that are a subset of the target PBC, so in total, we had maybe 600 patients, a lot of patients in the target PBC, but specifically patients who returned questionnaires to us, over 200, and 37% reported what was called clinically significant itching. So in a scale of 0 to 10, the clinically significant were 4 or more. And based on the PBC-40, actually it's a 1 to 7, so 4 to 7 would be clinically significant. So one question I get often is, okay, I itch, but how do you know? How do I know it's the PBC and not something else? Well, typically, the itching in PBC is not accompanied by a rash. There is no rash. It starts out without a rash. Of course, over the years of that trauma to the skin, you develop some chronic changes. The skin can get thickened, it can get red, it can get bumpy, nodular sometimes, okay? But it's not like eczema, where you start with a rash that itches, for instance, okay? So that helps the physician differentiate. It's intermittent. Many times patients will tell me in clinic, no, doc, I'm not itching, but yes, I did before and it stopped, or it comes and goes, right? And it's worse in certain months of the year, certain seasons. The summer is worse, and it's worse in the heat. And in addition to the seasonal variation, there is a diurnal variation. You're not crazy. It is worse at night. That's very common. And the picture I showed there, I took from Nora Bergazza's paper, one of the early investigators in itch. She's a physician in New York. And she published this from scratching your backs, which is very striking, right? But tells you how cumbersome this can be. Why? Why do we itch? We all want to answer this question. It's $1 million question. We heard a lot about bioacids before, and bioacids are a major player in itching in PBC, but they're not the only player. So player, the name for player for us is neurotransmitter, or that would be a substance that activates itching receptors. So the picture that I have here on the left is just a schematic. So the skin will have receptors, and there are substances that can activate or trigger those receptors. And once these receptors are activated, the signal is transmitted to the brain, where it's perceived as an itch, and then there is a response, which is the scratch. Okay? Several neurotransmitters have been implicated. You heard about bioacids. There's lysophosphatidic acid is one that correlates a lot with the intensity of itching in cholestatic diseases, and others like serotonin and the endogenous opioids can be an important one, although there are more recent work maybe countering that. If you go for a walk, if you go for a run, those of you who like to run or exercise, sometimes you start itching right in the middle of your exercise. That itch is because you're releasing your endogenous opioids, it's the endorphins, right, that make you happy. That's high when you exercise. And that they make you itch. So there is a theory, because early studies have shown that in patients with PBC, there was an increased level of endogenous, your own opioids, and that could be part of the reason for the itching. There's no correlation between those levels and the intensity of itch. There is no correlation between how high the bioacids are and how severe the itching is. It's very hard. It's probably multifactorial, multiple players here contributing to the symptom. We know that you see in purple there, the inhibitory neuron. So when the response is coming down from the brain for you to scratch, there is a neuron that can stop that response and say, don't scratch anymore. That's one type of opioid receptor that is stimulated there. So opioids, there's, you know about morphine. Morphine stimulates the mu receptors, and morphine causes itching. Demerol causes itching. There's another receptor called kappa, and that's the one that is there. And when kappa is activated, there is actually a blockage in that signal. So activation of kappa blocks itching. So one of the hypotheses is that what we have actually is an imbalance in these receptors in PBC. We have more mu than kappa, so we have more itching, okay? A lot of research needed in this area, but that explains some of the drugs that we have now under evaluation for itching. Now, not for evaluation, for management of itching. Now, itching, evaluation of itching is not witchcraft. There are ways for us to quantify that, and it's important because of that discrepancy. Sometimes I ask my patients, okay, you have itching, so how bad is it? Doctor, it's really mild. Okay, from 0 to 7, it's a 7. Okay, or the opposite. This is crazy, this is killing me, it's very severe itching, I can't sleep, I can't function. Okay, 0 to 10, it's a 5. So what that tells us is the way we perceive a symptom is very subjective, it's very different. So we need to try to quantify, when we do research, we need to try and quantify that in a meaningful way that we can then calculate if there has been improvement with the intervention that we are starting, right? That's the challenge in the world of itching for my colleagues in the industry here in the back. So there are many ways. We can ask them or you to draw a line in this scale from 0 to 10. There's the 5D questionnaire on the right there that tells us more than just the intensity, but where it is, how many zones in your body, is it getting better, getting worse, and the PBC 40, which is a broader quality of life questionnaire for PBC with 40 questions, and it evaluates several domains of the quality of life. It evaluates symptoms, not just itching, fatigue, sleep, emotional. There are several domains, and we can evaluate in particular the itch domain of the PBC 40. There is a wide discrepancy between what you report and what your clinician thinks that you have. Right? So in the target PBC, we had the opportunity to study that. This actually happens in a lot of diseases, in cancer, many other diseases, but they had not been studied in PBC. So we had the opportunity to compare what you filled out in that questionnaire and what the doctor wrote in the clinic note. Okay, and there was wide discrepancy. until the itching was severe. At that point, our opinions converged. We could tell because it's horrible. Sometimes I'm in clinic with a patient with severe itch, and we all know, right? It doesn't stop. So that there is no doubt. But for the milder itching, there is discrepancy. So we encourage you guys to tell your doctor how much that is affecting your life, because only you know that. And we saw that the higher scores, itching scores, were associated with a lot of other changes in your life: depression, anxiety, social isolation. In our study, there was a correlation between alkaline phosphatase and itching, and the severity of itching. That's not always true. That has not been shown in many, there's one other study showing the same thing. So there's some doubt there. But know one thing, you can have, and I'm sure some of you will vouch for that, you can have a completely normal alkaline phosphatase and still itch, right? So treating the PBC with urso, with obeticholic acid, with whatever we're using, even if you can completely normalize all the liver chemistries, you can still have itching. That's something that sometimes your doctor doesn't understand. This is a paper we published with the target PBC data. And let me break it down for you, because I know it's busy. But it's exactly to show you. Of course, that helps if I point the right direction. So this is, imagine the PBC-40, I told you, several domains. The itch domain, the emotional symptoms, fatigue, social, cognitive. And there are 2 bars. One is for 3 bars. No itch, mild itch, significant itch. And what you see here consistently is that, those with more severe itching, here you go. You have worse scores for the other domains: emotional symptoms, more fatigue. If you don't sleep at night because you're itching, you're gonna be more tired next day. Social, with the social isolation, cognitive decline, all of that. That speaks for itself. Okay. So itching, and this, again, you know that better than your doctors. We are doing a lot of work to educate the clinicians also to understand this systemic impact of itching in your lives. Here are some quotes that I heard from patients with PBC, and again, I want to tear my skin off. It's relentless. It messes up with your mind. And nobody offered me, to me, that's the worst one. Nobody offered me a medication. How is that? How can we believe that treatment was not offered for itching? Obviously because nobody asked, or either the patient or the physician or both didn't know the association between itching and PBC. So that's why what I tell my patients is that it has to go from both sides. Education goes on both sides. So tell your doctor if you see somebody else, my patients obviously don't have that problem, but they have to be vocal and say, okay, this is related to my PBC. I heard, I read, this needs to be treated. In target PBC, fewer than half of the patients with clinically significant itching received treatment. And when they were treated, we got a lot of antihistaminics, which are not even in among the recommended drugs for treatment of PBC as first line. And then we had some cholestyramine, rifampin, sertraline, and others. So how do we manage the itch? Well, general advice first, and this seems minor, but it's not really, it helps. Keep your skin moist, because dry skin makes the itching worse. Well, dry skin is a cause of chronic itch, even if you don't have PBC, right? But so keep the skin moist. Trim your nails to avoid excoriations on the skin. I had a patient sleep with mittens because her face was all getting excoriated. Avoid very tight clothes, because that makes also the itching worse. Wool, cold packs. And each of you will have a different way to tackle the itching. I've heard different things like menthol gel, which I would think could make it worse, but some patients tell me make it better. So find your way, but there are different topical things to provide relief, especially if it is a limited area of the body that is itching more. Guidelines. Here is what the AASLD guidelines will recommend, except for the stars that I added there. I'm going to explain that to you. And ESO has a similar approach for now. So we start with the general advice, and this is another thing. Just because you're itching doesn't mean that you need to be on a pill or a medication to treat it. There's a lot of variation. I ask my patients, how bad is it? Do you want to be treated? Many patients don't, because you don't want to take an additional medication because you're afraid of side effects, and some of these drugs are not very well tolerated anyways, or because it's mild and you feel like you can deal with it. It's personal. It's a personal decision. You have the choice to tell me, yes, I don't want to deal with it, give me a medication, or no, you know what, I'll tell you, doctor, when I'm ready for treatment. So establish that communication with your clinician. The first line agent is cholestyramine because bioacids do play a significant role in the itching. So we give cholestyramine, and I'll have another slide with dosing recommendations. The maximal dose will be 4 packets a day, which I usually split in twice a day, 2 in the morning, 2 at night. And there's some posology recommendations. It cannot be given. You cannot take this together with your urso because it's a bioacid resin, and urso is a bioacid. If you take these drugs close together, they will bind in the gut and nothing's going to work. Okay, so that's very important. We're going to talk about this again. But cholestyramine is first line. If it doesn't work, then we have options. We have rifampin, which works through different mechanisms. We have naltrexone, which is an opioid antagonist, right? We have sertraline, which is Zoloft. It's an antidepressant, and that's another thing. Sometimes patients tell me, I don't want anything that messes with my mood, or I'm afraid of taking it. I'm not depressed. Why are you giving me this medication? But it's because sertraline is one of those neurotransmitters that has been implicated in the causes of itching. Then we start going into experimental therapies, and I put that in quotes because they were experimental up until recent, some of them. Fibrates. So fibrates are what we call PPAR agonists, and anecdotally, these drugs have been shown in the past in PBC to improve the itch. And now we have moved beyond anecdotes and case reports. There is a study I'm going to show you that really showed improvement in itching with bezafibrate. Now, we don't have bezafibrate in the United States. We have fenofibrate. And for pheno, there are only anecdotal reports. The IBAT inhibitors, so you heard from Sarivak earlier about, and probably from Janine before, we'll talk about IBATs. IBAT stands for ileal bioacid transporter inhibitor. So that goes back to the importance of bioacids in the itching, right? And just to recap how that works, we have the enterohepatic circulation. What is that? So the liver will produce the bioacids. They're secreted in the gut after a meal to help with digestion. They go through your gut. When it gets to the end of the small bowel, they are absorbed again and they recirculate. So we like to save things in our bodies, right? So we keep this bioacid circulating. And what this drug does, it blocks that absorption. So we interrupt that circulation of bioacids, and that has been shown to improve itching. We'll show you some preliminary data. I'll go into the other experimental therapies, and then for the most refractory cases, like really, really intractable itch, we can offer liver transplantation. So here's the dosing for cholestyramine, and you see side effects include bloating, constipation, unpleasant taste. It says constipation, but some patients have constipation, some have diarrhea, actually, with that. And it should be dosed 1 hour before or 3 to 4 hours after every other medication, especially the urso and thyroid medications. That are the ones that you have to pay attention to, okay? Colestipol is an oral medication that acts similar to cholestyramine. Then rifampin is a drug used to treat tuberculosis, and it inhibits another receptor called PXR, and also it's very efficacious for itching, very efficacious. We see dramatic responses. The caveat is that it has a maybe 4% chance that it can cause drug-induced injury with some hepatitis, so mild elevation of the liver enzymes. Usually it's reversible as soon as we stop the medication. In Europe, that is actually the first second-line drug. So if cholestyramine doesn't work, in Europe, everybody goes to rifampin as second choice. Naltrexone, as I said, opioid antagonist, and sertraline to inhibit serotonin. This butorphanol, I'm just going to throw it here. Those are some case reports we worked on. I got 8 patients with cholestatic diseases and refractory itching. This was a couple years back. So this drug, remember how I explained that imbalance between the opioid receptors? Let's call them the good and the bad for the purpose of itching. So this drug, it stimulates the good receptor and it blocks the bad one. And by that means it can mitigate the effects of the itching. It doesn't stop what's causing the itching, but it stops your response, the scratching response. So it changes how patients perceive the itch. And we saw significant improvement in 5 out of 8 with the side effects of somnolence, nausea, and dizziness. This is a nasal spray. So we usually, for our patients with liver disease, we usually give them like 1 spray at bedtime or 1 spray twice a day, alternating the nostrils, and that can provide relief. I use that for the very refractory patients as a last option. How about the fibrates? Going back to that data in our stepwise approach. So this is data from Spain. This was a study with bezafibrate for patients who were not responding completely to ursodiol, okay? And here we're not looking at the response in terms of alkaline phosphatase. We're focusing on what happened with the itching. Remember, I said we can measure the itch. We give you that line to cross from 0 to 10. So this is what it was. They did it at the beginning and at the end. And at the beginning of the study is the graph on the left. The mean score was 4.4. If you add them all together, divide by the number of patients, the mean was 4.4, the intensity of the itching. And with the drug, you can easily see the direction of the line going down. At the end, it was 0.8. Okay, great improvement. The graph on the right shows what happened when they stopped the drug. The itching started again. So that was observation from an open label. This was not a randomized placebo-controlled trial. Okay, so there may have been some biases there, but that was observed. And then in the Netherlands, they did a randomized controlled study called the FITCH trial. And this included 77 patients with cholestatic itching. As you see, 44 PSC patients, 24 PBC, and 2 with secondary sclerosing cholangitis. Everybody to enter the study had to have more than 5 in the itching intensity. And what we saw specifically for PBC, the alk phos was reduced by 36%. We know that bezafibrate improves alkaline phosphatase. The graph A will show you all comers, PBC, PSC, secondary sclerosing cholangitis. You can see 45% of patients in the bezafibrate group improved their itching by more than 50% comparing to patients on placebo. And then when we looked at separating PSC and PBC, there in graph C, we can see that it even if you separate just PBC patients, it works beautifully. You know, because of this study in the new EASL is the European Association for Liver Disease, the new EASL guidelines for primary sclerosing cholangitis, which is this other bile duct disease, they put now bezafibrate as the #1 treatment for itching. We are not there yet in the US. We don't have the drug here even, but just to show it's really effective for itching. Right, how about those of you who are on obeticholic acid and you have itching as a side effect? Well, first, my recommendation is always, before starting OCA, let's try to control the itching, right, the best we can, and then we add OCA. Start with your conservative measures, then you can carefully add cholestyramine, provided you keep those posology recommendations to try not to modify the dose if it's working well for you. But we can also do dose titrations. We can reduce, if you started at 10 milligrams, if you are at 10 milligrams, you can go down to 5 milligrams daily, or you can alternate. If you are on 5 milligrams, you may have to take it every other day, and sometimes even drug holidays are necessary. You may know there's a study going on combining OCA with bezafibrate. So it's a win-win in that sense, right? If there's any itch, it's taken care of by the bezafibrate, and we can potentiate the improvement in cholestasis. So that study is ongoing. For the other experimental therapies, you might have heard of UV light therapy. This used to be very time-consuming. And when that study was published, which is 10 years ago already, 2 hours a day, 3 times a week. But now it looks like the potency of these lights have changed. It can be like a 15, 30-minute session. For intractable itching, it's very temporizing, and it's just, by the time it doesn't last for too long, the improvement. We can have nasobiliary drainage. This is a very aggressive, well, I consider it aggressive because you have to put a nasal tube that goes all the way to your gut to basically drain the bile out. In PBC, we don't see that great benefit. There are some other causes of chronic itching for which this can last for months, the improvement, but in PBC, it helps you for a couple of weeks. We need better than that, right? Plasmapheresis, which is when you are admitted to the hospital. This is similar to dialysis. You have big catheters that drain the blood out. The blood is filtered to remove the bile acids and other pruritigenics that could be other substances that could be in the blood that we haven't even identified and that cause itching. So I have used that for a few patients, again, last resource type of thing. And transplantation, which is amazing. It's just amazing how a patient could be scratching like 20 out of 10, and the moment they come out of the OR, there is zero itching. All right, but we have better therapies coming up. We have a new horizon there. Going back, and I use the terms interchangeably. ASBT is the same as the IBAT. So we have 2 drugs that are in the market now, as was presented to you before. Maralixibat is approved for Alagille, and odevixibat is approved for PFIC. Those are pediatric conditions that also cause very significant and burdensome itching. And they are approved by the FDA and in the process of being approved in Europe as well. And under evaluation for PBC now, we have linerixibat, which is undergoing phase 3. Volixibat is a phase 2-3 trial that is also ongoing for both PSC and PBC. And we have CARA, which is difelikefalin. It's a kappa agonist. Phase 2 going for PBC, that stopped. That study was interrupted. Now we're waiting for interim analysis. And I didn't list a science. They will kill me. Don't kill me. It's because it was we're just recently enrolling. But that's another study. It's a whole other different mechanism of action that you're doing for PSC and PBC. Please don't kill me, Terry. Okay. Linerixibat, I'm going to show you data not because I have any preference, but because this is available already presented in the liver meeting. We have data from the Glimmer trial, which was the phase 2 study. 5 doses were studied comparing to placebo. And I'm showing here the 2 doses that showed more significant changes, the 40 milligrams twice a day and 90 milligrams twice a day. And the placebo is in light purple. You can easily see at week 16 how there was improvement in the itching scores. Here, this is where you should look. So this is undergoing phase 3 now. The difelikefalin, the CARA trial, we don't have data in PBC, but in renal patients, they also have chronic itching. There is significant improvement there. And I will conclude with this quote, because instead of just citing how bad you feel when you have itching, I want to cite how good you feel when you don't have it. And that's what I hear from my patients. I gain my life back. I think that's really powerful. I'm going to stop here and take your questions. Thank you.
Awesome. Great discussion, Dr. Levy. Appreciate that. So we have a couple quick questions. I didn't know if you mentioned during the cholestyramine discussion on kind of the guidelines. Is that available in capsule form or just in the...
Cholestyramine is a powder, and you have to dissolve it in a glass of water or juice. I usually suggest the patients can put half water, half like orange juice for the taste. And that's only oral, only powder. The cholestyramine and cholezevelan, so cholezevelan is the capsule form that you can take.
Oh, so
it's a different, it's not cholestyramine, it's cholezevelan, I can say that. That's Welchol.
Okay.
Okay.
But that's not used for...
It can be used. What happened is there's only one study for Welchol, like in PBC, and that was done for patients who failed everything else. So they had already failed cholestyramine, so very few patients improved with that. But if you haven't used the cholestyramine, or if you use it and it helps and you want to try to do the capsules instead, the Welchol would be the one to do.
Great. And there's a comment about kind of the bias as far as evaluating your itch after you go past the baseline, right? Not being at zero anymore. How do you help address that or talk that through with patients? Like, people without PBC itch are zero. You get to a certain level. How do you kind of talk about that change in where their baseline now is?
I'm not sure I understand the question. The bias I was talking about is because itching is so subjective. If I give you a treatment and I tell you this will help your itching, then you're primed to believe that your itching is going to improve. That's called the placebo effect, right? And regardless of what I'm giving you, we will see improvement. A third of the patients will improve the itching. Usually that lasts no more than 2-3 months, and then the person goes back to their baseline. So when you do clinical trials, there are ways that this can be adjusted for and studied. So that we can discount that effect and really decide what's due to the drug or due to the placebo effect. That's what I refer to. When you do an open label study like that Spanish bezafibrate study, everybody got bezafibrate and they knew it could possibly improve their itching. So, you're more prone to think, yeah, I'm improving. That's a bias.
Okay, great, thanks. And there's a question regarding Remeron for itch.
Is Remeron mirtazapine? Yeah, so there's very limited data. I don't know that it really works. I have had patients ask me, can you try that? And I don't see great improvement, but also I only have like 2 patients on it. And it's a psychotropic medication, so it affects your mood, mentation, sleep. And a lot of patients don't want to be on that medication exactly because of that side effect. So I don't have a lot of experience with mirtazapine. Yeah. But I know it has been studied for itching with limited data.
Yeah, I guess, and kind of messing up the sleep versus itching. Yeah, it's probably tough call. There was a question about using, you mentioned, I guess, SAMe to control itch during pregnancy. Mm-hmm. Can it be used if you're not pregnant?
Yeah, there are no studies, but you can try. It's over the counter, it's safe. In general, I have my own bias against supplements simply because they're not regulated, right? So we don't know what's in each capsule. We don't know the dose. It's not what's written in the box. The NIH has conducted a study looking at silymarin. Everybody here heard about milk thistle, and I'm sure some of you are taking it. So milk thistle, the substance is silymarin, and in studies, it's pretty safe. It may actually decrease some inflammation in the liver. That's all it does. It doesn't cure anything. It doesn't really treat anything. But it's safe. Silymarin is safe. So patients want to take it. However, when you mix it with other stuff and you put that in a pill, God knows what's in there because it's not regulated. So the NIH looked at they took 100 capsules from one bottle and they analyzed each one. Each one had a different concentration. You go from 400 to 1,000 to 200. How can I trust? And you don't know what other things may be mixed in there, what concoctions. In Europe, there were cases of heavy metal intoxication because of mercury in supplements. So I don't trust it. I don't like that my patients take it. But SEMI itself has been used for itch and it's safe.
Okay, good to know. And as far as fibrates taken with decompensated cirrhosis, can you take fibrates with decompensated cirrhosis?
So there is insufficient data. It's currently not recommended by the guidelines.
Okay. And then when the clinical trials are over, is it likely they'll be safe for cirrhosis, fibrates?
Currently, well, fibrates are not under evaluation in a clinical trial now. Here, there was a study, so bezafibrate, there was a large study for PBC, randomized controlled trial, the Besurso trial. It did not include decompensated patients. So we don't have that information. Right now, it's not recommended.
Okay. And there was a question around melatonin and serotonin and kind of that. Is there an interplay there at all?
Melatonin?
Yeah.
For itching, not that I know of.
Mm-hmm. Okay. It doesn't affect the serotonin levels, though, or anything in your body? Okay.
Not that I know of.
Okay. Cool. I think those are our main questions. Oh, one last question. Oh, sorry.
Thank you for asking that. So in early stages, cirrhosis is well compensated.
Oh, sorry. I'll repeat the question.
The question was, how do we differentiate cirrhosis and decompensated? What is decompensated cirrhosis? So decompensated cirrhosis is more advanced stage of cirrhosis where you start having some complications. That's when you have portal hypertension, you can have varices, so veins, ascites, encephalopathy, you have more significant synthetic dysfunction. So the liver is not working that well, not producing the substances that it needs to produce, not cleaning, detoxifying the way it should, and it's not eliminating bilirubin, secreting the same way that it does. So that's decompensated disease, a more advanced stage.
Great, thanks. And one last question around kind of recording and documenting your itch levels. Do you have your patients kind of keep track, like a log, daily, weekly?
No, because as Leslie mentioned, PBC doesn't define it. I don't want people to live and breathe every moment. Oh my God, I have PBC, I have to do this. I don't think that's healthy. But when I start a new medication, for instance, then I say, well, keep track of that. See if that's helping you. Let me know. But no, in the daily lives, unless you're participating in a trial, I don't see a reason to do that.
Mm-hmm. Okay. Great.
I think somebody has a question
is there another?
in the back.
Yeah.
The varices that you just spoke of.
Uh-huh.
Where is that located? You're not speaking of like varicose veins in the legs.
No.
You're speaking of abdominal varices?
Yes. Thank you. So the question is, what are the varices? What am I talking about? Not the varicose veins it's the same name, but it's not the varicose veins that you have in the legs that we all get. No, that's not it. The varices that develop when you have cirrhosis, the ones that we're concerned about, they're located in the esophagus and stomach mainly. There's some other atypical locations, but inside the body, inside the GI tract, that's what we're worried about.
Great. Thank you, Dr. Levy.
Yeah, well, thank you.